Final speaker for this session is Dr. John Breinholt. Dr. Breinholt is the Chief of Pediatric Cardiology at Memorial Hermann and the University of Texas Health Sciences Center. He will talk to us about what to expect from common congenital heart treatment procedures. Dr. Breinholt.
It's a pleasure to be here. I appreciate the organizers of the meeting. Some of you may wonder why you have a pediatric cardiologist speaking. But as many of you know, one of the things that we find is that we were having a conversation upstairs with a family, and one of the things we were talking about is one thing that every adult that has congenital heart disease has in common with a child with congenital heart disease is you're all born with this. And so this is what I do. And so I spend my entire day working with, in my case, mostly children that were born with congenital heart disease. And there we go. And so when you become an adult, it's something that is very familiar. It's very familiar territory for us. And so what I do is those of you that know Dr. Lin and I work together quite a bit, and I'll actually show some things of some of the work that we've done where we kind of use our respective expertise to come together to hopefully help you out the most. I'm going to talk a little bit about the cath lab experience. I'm sure that there's many of you who, either you or a family member, have undergone a cardiac catheterization, so none of this will be new. But I do think that some of it is important, particularly when it comes to having an understanding of some things that are happening, because probably the most important thing are the things that you can do to either help us understand things better or questions you can ask so there's no surprises. So we'll kind of go over the kind of what happens before and during and after, and there'll be throughout this some of the things that we can do now that weren't always possible in years past. So the first question is why? So there should always be a reason. I love what I do. Some people compare surgeons or even cath docs to barbers. You know, if you ever ask a barber if you need a haircut, what are they going to say? Of course you do. But the truth is, I don't enjoy doing procedures if a person doesn't need it. And so it's always important to understand why. What is the purpose and what are you trying to accomplish? Where are you going to have your procedure done in an adult hospital, or are you going to have your procedure done in a children's hospital? Which most adults in the world would say that's a crazy question, but it is not crazy for this audience. When? What is the schedule? When do you have to stop eating anything? How long are we going to starve you? Should you take your medications before? Is it okay to be without your medications? All of these are important questions to answer. How? Something that we actually wouldn't ask very often in the pediatric population is whether there will be anesthesia or not. In some settings, you may have a general anesthetic, be on a ventilator, or others you'll have sedation in which you will be at the very least arousable or be completely awake during the procedure. That should be very important for you to know before you walk into that room. What are the risks and benefits of the procedure? Is this going to be interventional, or is this simply going to be a kind of a search and figure out what's going on type of experience? And then who is going to be the person working with you? Is it going to be an adult cardiologist? Will it be an adult congenital specialist? Will it be a pediatric cardiologist? It's certainly somewhat strange to people when I walk into the room and they're saying, I'm 50 years old, I'm older than you. What are you doing working on me when you're a pediatrician? So it's always important to understand who's at play, or in some cases, when I'm working with Dr. Lin, understanding that Dr. Lin has brought me into the procedure to work with him. It's always important to know who's working with you or your family member. There's always going to be often some blood work. We may want to look at kind of what the balance is in your body of electrolytes, want to look how your kidneys are working, how your liver is functioning, certainly, because some of these things are very important both for the procedure as well for our understanding of what we're looking for. What is your platelets like? Will have to do with bleeding, your blood count, clotting factors, and a type and screen. If we're going to do a complex or potentially higher risk intervention, we want to know that we can provide support for you should something unexpected occur. What are some of the testing? So we may be seen as the test, but sometimes there is information we need before we go in. It might be an echocardiogram. Increasingly, we're starting to see the use of cardiac CT, cardiac MRI, vascular ultrasound, which can be used to help determine where we're going to get access to get into your heart. Sometimes simple things like chest x-rays. Some of the do's and don'ts are related to what anticoagulation might you be taking, what blood thinners are you taking, do you need to shave parts of your body relative to what we're going to do, how well hydrated should you be, how are you doing, are you well? You know, sometimes people anxious to have a procedure may not want us to know you're not feeling well, but how you're feeling can be very important for what we're doing, and even more importantly, for how you're going to look on the other side of the procedure. Things related to your medications, to what that may or may not interact with the medications you received during the procedure, and certainly how are you getting home afterwards. I don't have to worry about that because my patients usually are being carried home, strollered home, put in a car seat home, but if you come alone, you may have a hard time because they may not want you to be driving after this. So the day of the catheterization, arrive early. It's always good to get there, get your sense of things, be comfortable, lower your anxiety. Bring friends, family, have them bring a book. Bring any questions that you might have. I think it's always important. Information is always important. I never like surprising people. Before a procedure, when I sit down with the family, I tell them very scary things. I tell them all the possible horrible things that might happen in the cath lab, even if there's just a tiny, tiny risk that it might happen. And I always say I would rather scare you now than surprise you later. So it's always important to ask questions and have a good understanding of what is going to occur. And then as far as some of the pre-cath procedures that might occur, some of which might be repeating blood work that you've had, a placement of an IV, placement of an arterial line, a consultation with anesthesia, particularly if there's a lot of complexities, basic information from the nursing staff, and certainly the consent form. We talk about informed consent, but this is particularly important for some of the types of things that we do. And of course, again, last minute questions. When you get in the cath lab, again, for adults, is it going to be a sedation versus an anesthesia? Are you going to just get some medications to make you relax, to feel comfortable laying on a very hard, flat, cold surface? Or are you going to be completely under anesthesia and protected by a ventilator and have an anesthesiologist monitor, not just monitoring, but even controlling some of the way in which your body and heart are working? Is there going to be use of local anesthesia? Often we will give numbing medication for where we're going to enter so it's more comfortable, both if you're just sedated in particular, and also at the other side of it to where when you wake up, you don't have this pain in the part of your body where we entered. For us, it's usually the leg, but it could be your leg, it could be your arm, it could be a number of things, which I'll talk about in a minute. The vascular access, any type of diagnostic, sometimes we might do some diagnostic studies in the cath lab before the actual cath, transesophageal echocardiogram or things of that nature, and then certainly there's the intervention. Anesthetics, we just heard a great talk by Dr. Monteiro about anesthesia, but in simplified form for us cath jockeys, you have general anesthesia, inhaled versus IV, moderate sedation, which might be just something that reduces your anxiety, or some type of medication that would relieve pain associated with the procedure. I mentioned access sites, so common places for us to enter in children are usually leg, neck. In adults, it can expand to where it might be in your arm, near your hand. Sometimes for us, we'll even go up higher because in children, these vessels are a little too small. So I've entered in up here in the brachial or in the axillary artery, can be in the leg, can be in the neck. Sometimes if you had catheterizations multiple times, we lose access to those blood vessels and have to find more unique ways of getting there, and sometimes we go through the liver. It sounds crazy and people get really nervous, but actually it's about as straightforward as everything else. And it's always important to understand. It kind of goes back, I kind of think about when the comment I made about shaving. I would really hate for you to shave some part of your body and then we go somewhere else, you probably wouldn't be very happy with this afterwards, because you just wake up with multiple shaved areas. So the cath itself, there's going to be pictures taken, going to be information about the pressures in your heart, the way in which your heart interacts with your lungs. Oximetry is like the blood, your oxygen saturation, and you've heard that all your lives, those of you that have congenital heart disease. And you're often thinking about when they put the little ET light on your finger. But this, we measure blood oxygen saturation in multiple locations within the chambers of your heart and the blood vessels, because all of them and what they are in different places mean something. And we use all kinds of math afterwards to kind of figure out how things are working. There's the intervention. Sometimes if there's elevated pressure in your lungs, we're evaluating that. And then sometimes we work your heart in ways kind of artificially so that we can understand how you're responding to that. And then sometimes we're looking at information on your left side of your heart versus on your right side. And of course, for some of you, that also has different significance of what is right, what is left, or if there's only one left. These are some of the types of pictures that we might take of the blood vessels. This is the angiography that helps us show the structures, that help guide some of the decision making. And then there's interventions. And with interventions, they can be things like placing of stents. In adult cardiology, the primary place for stents are usually in the coronary arteries, which is, by the way, something I've never done. I've probably placed stents just about everywhere else. Or coils, plugs, different devices to close off extra blood vessels. Some of you that were upstairs might have seen some of those devices. Balloons to dilate structures. We can implant valves. We can implant valves in the aortic position, in the pulmonary position, in the tricuspid. Pretty much we can put a valve almost anywhere in the heart, not in every situation, but certainly they've all been replaced by a transcatheter valve given the circumstance at this point. And then there's also things like ventricular assist devices that can help support procedures, or can be what's the procedure you're having done if your heart's struggling. And so here's some of the things that we've done. This is the Impella device. This is actually a support pump for the heart. This is showing it for a left support, and you can see a catheter that goes up, goes across the aortic valve and into the heart. And then this actually allows us to bypass the function of the left heart, or support, more importantly, the left heart during a procedure, or this could be the procedure because you need this type of support. There are surgical alternatives to this, but this is just one of the interventional cardiology ones that can be done. And this is an example of a transcatheter pulmonary valve. This is the Edwards Sapien valve. And you can see it's going up through the leg, and we cross and put it in. You can see where the suture lines, because this is usually in people that have had some type of conduit or surgery before, that the valve is no longer functional, and this is the implantation of such a valve. And then you're left with a competent functional valve. Now I'm going to show you a couple of things that Dr. Lynn and I have worked together, and actually this example I have right here. People afterwards can come up and take a look at it. This is a 60-year-old gentleman who had cirrhosis of the liver, not our disease, had hepatocellular carcinoma, and was found to have a large sinus venosus ASD, which is actually an ASD that we usually don't close in the cath lab. It's usually a surgical closure. The problem was there wasn't really any heart surgeons that were very interested in dealing with a gentleman that had hepatocellular carcinoma and cirrhosis of the liver. And he really needed a liver transplant, but the liver transplant doctors didn't want to touch him until his heart was corrected. So the two people needed to help him, didn't want to help until the other one did their job first. So we said, well, hey, maybe there's something that we can come up with. And so actually, most of the credit really does have to go to Dr. Lynn, who was a genius in thinking this through. And what he did is he said, maybe if we place a stent that has a covering on it, they will cover the valve, cover the hole, that will do the trick. But we had this abnormal blood vessel that came in that really needed to go into the left side of the heart, but would come in right by where we would put this stent. See if I can. So it's actually, this is the blood vessel right here, and it would come down, and we needed to go right behind here where the stent would be placed. And so what he did was he had this patient come in and had an MRI, and then the MRI was turned into a life-size model of his heart. And so when we took the device that we had planned to use and we tested it, so this was our trial run to see if it would work. And when we could see that, at least the model looked like it would work, we decided we're going to give it a try. So we took the gentleman to the cath lab, and what we did is we placed it on the right side. You'll see this is it being done in the model. The left side is it being done in the gentleman. And this is the deployment. The stent came up from the leg, and then it was opened up, and as you can see the catheter coming down here, you see the stent opening up. And these markers here were created from the MRI to show us where our landmarks were, where the hole was, where where this is where the pulmonary vein was coming in, and this is the entry into the heart. It seems like the entry is up here, but it's actually down here. And so we were able to successfully deploy this. And then afterwards, this is just showing the CT that was done, kind of evaluating. You can see the stent extending all the way down, and successfully did what normally would have been a surgery, was then closed, and then he could go on to have his further procedures. I don't think they can do liver transplant in the cath lab yet. This is just showing some of the imagery of when we do this, where we can actually create these kind of CT-like movements with the cath equipment. And you see this normally if you're in the cath lab. This is not always happening, but we sometimes will do screens like this, and this allows us. We actually did this of this model, and then we did it of the patient. We were able to fuse the images together, which helped guide us so we kind of knew where things were. This is another application. We had a patient at tetralogy flow, probably familiar to some of you, who had some problems in the pulmonary valve, which is usually where the problems are when you guys grow up. And so we did the imagery. We created this with this three-dimensional image, and showed us the landmarks, and then we were able to use those and superimpose it on the patient's heart while we deployed the valve. Here's another example. This was a 42-year-old gentleman who had very high blood pressure. It turns out we suspected it was a coarctation. Those of you that don't know what a coarctation is, it's when the blood vessel that leads the heart, the aorta, as it comes around the candy cane shape, becomes very narrowed. So we thought that's what it was. We were wrong. It actually was more than that. It was actually not just narrowed, it was actually completely closed off right where the narrowing was. It may have at one point been a coarctation, but it later became a complete interruption. And he was at high risk for a history of stroke to undergo surgery for this. So, and this is how we found it. We got in and we got the wire down here and found out, oh, we couldn't get the wire to go any further. And then the picture, these are actually two separate pictures. That's one picture and that's a picture from below. So close, not quite. So, and this just shows the CT rendering, and you see where something stops and then it starts up again. So what we did is we took him, we got access in his arm, and we came down from below, and we had a wire that actually had, you can apply energy to, and burned through that interruption, and kept going, and then burned through the other side. And I think we both lost a few years of our lives when we were doing this. And then once we did that, we were able to, with a snare, which also served as a nice target, lassoed that wire and then pulled it up, and then pulled it out of the arm, and then we're able to put in a stiffer wire that allowed us then to put an introducer sheath across. So here we're taking a picture, we know to prove that we're across. And then we took a stent, again with a covering like this. This is a typical stent that you might think about where it's like a wire cage, but this is one that has a covering on it. We needed the covering because we knew there was a part in which there was no tissue, so we needed to replace that. And then we were able to deploy one of those across the area where the interruption was, and he had a resolution of that. And I've seen patients, when you relieve this type of problem, either through an interruption or even a severe coarctation, go from being on 3, 4, 5 blood pressure medicines to none. So that's some of the things that we can do, and the fun thing about what we do is we can always try and come up with new things to hopefully help you when problem arises. So then after the cath, so after you going through crazy things like that, you want to be watching for bleeding from where we went through. Most important thing, I always tell people, if you see blood, never do this, always do this. Always put your hands on it, stop it from bleeding, hold it for at least a good 20 to 30 minutes before you peek. Most of the time will take care of itself. Certainly a good idea to let somebody know. Fortunately, it doesn't happen very often, but it does happen. What kind of activity you can or can't do, what type of rest that you need, when you can get back to normal activity, when can you get back to lifting weights or lifting heavy objects, when you can get back to competitive sports. All those types of things vary depending on what you had done. What do you do if you have a fever infection? And with a lot of these things, you have to remember something's just been done to your heart. So even if you feel something you felt before and didn't think it was a big deal, oh, it's just a cold, you just had a procedure, we just might have implanted something in your heart, a fever might have more significance than a fever beforehand. When is your follow-up, what to anticipate for your follow-up, and what type of testing might occur. So in summary, so we've talked about what to do before, what to do during the day, kind of what we do in the cath lab when you're asleep and you're not paying attention, and how to kind of look at things afterwards. And as I said, it's always important to ask questions. We're always happy to explain what we're going to do because it's always best to be informed. Thank you.